So hello everyone. So in this lecture series, we are going to learn about congenital talipus equinovirus. Congenital talipus, talipus equinovirus. Okay, equinovirus. So equino has come from the word horse. Okay, horse, and talipus means foot. Okay, and congenital means it's by birth. It's by birth, and you need to remember that varus means it's an inward deformity. Inward deformity. As you can see in this child, the foot has been adducted, that is, it has gone towards the midline. This is the midline of the body. The foot has been adducted and it has gone into a varus deformity. Okay, this is a varus deformity. Okay, varus deformity, and this foot is is present in the foot, right? So that is why the word talipus. Now there's the deformity known as CAVE, that is cavus, adductus, varus, and equinus. And during treatment of CTEV, we have to correct the deformity in the same way. First, we have to treat cavus, then we have to give adductus, then we have to give varus, and then we have to treat equinus. Okay. Now, what you need to remember about CTEV is, whenever we talk about CTEV, we need to remember that whenever we talk about CTEV, the most important thing that we should understand is uh, we do not want the disease to progress. So we treat it on time. So the contents of today's lecture will be introduction, etiopathogenesis, classification, diagnosis, and management. Okay, so remember there is forefoot, midfoot, and hindfoot, right? So, and there is an ankle joint. Okay, forefoot, midfoot, hindfoot, and the ankle joint. So cavus, adductus, varus, and equinus deformity are seen in this pattern. Okay, so forefoot will see cavus. Okay, forefoot will see cavus, midfoot will see adductus, hindfoot will see varus, and adductus will see in the equinus. Okay, in the in the ankle joint we will see the equinus. So the epidemiology is 1.2 out of 1000 live births. Remember, CTEV is more common to the developing nations like India, Pakistan, Nepal. Okay, in the basically in your South Asian region, but it is less common in the Western population. On contrary, developmental dysplasia of hip, it is more common. It is more common to the Western population. Okay, it is less common to the Indian population. It is more common. This DTH is more common to the Caucasian age group, Caucasian or fair people. Okay, fair people. So you need to remember the etiology is idiopathic, germplasm theory, retraction fibrosis, neuromuscular, genetic, and environmental. Okay, basically out in this etiology, what you should understand is different diseases like arthrogyroposis, multiplex congenita, arthrogyroposis, multiplex congenita, as well as poliomyelitis like disease. Okay, the disease that involves the neuromuscular system are more important in the case of this pathogenesis. So just remember, in this pathogenesis, yes, we have retraction fibrosis. Okay, but before the retraction fibrosis, what do we have is, suppose this is your tibia, this is your talus, this is your calcaneum. In front of your talus you have your navicula, and in front of your calcaneum you have your cuboid. Okay, and you have other things over here. So this is a foot like this. Okay, what happens is, this talonavicular joint, there's a joint, and this joint becomes weak. Now what happens is, there is a posterior medial bundle. Okay, there's a posterior medial bundle. Okay, that creates a pull, that is basically a fibrosis. Okay, posterior medial bundle means, as you can see in this diagram, that over here at this side, posteriorly and medially, when there is a pull from this one, the foot will actually come inside and lie inside the midline, right? The foot will come inside and it will lie in the midline when there's a pull in the posterior medial. Exactly the same pathogenesis is explained here. When there will be a subluxation of the talonavicular joint and there will be pulling of the posterior medial bundle, the foot will be adducted. Okay, you need to treat this on time. If you do not treat this on time, this deformity will lie prolonged, and at the end of the day, it is just like to maintain the foot. Okay, now antenatal diagnosis can also be done by USG for CTEV, and classification of CTEV is postural clubfoot, idiopathic, secondary, syndromic. Okay, certain syndromes are also associated with CTEV. Okay, now I already told you spinal bifida. Okay, other neurological defects, arthrogyroposis, multiplex congenita. Okay, certain syndrome like Mobius syndrome. Do you know this word from Mobius? What do you think? What do you think? In thyroid eye disease, you had Mobius sign. So this is known as Mobius syndrome. Okay, Mobius syndrome is also associated with at least one syndrome you can memorize. Okay, Mobius syndrome. So general examination, dysmorphic faces, eye is abductor palsy, Mobius syndrome, okay, and ear crumpled. So you can just, this is over as an approach. Okay, this is an approach. So let's come majorly to the CTEV. Okay, so remember in X-ray is very difficult to find because there are a lot of ossification centers going on. Okay, but even though we'll do X-ray, what we need to remember is in non-ambulatory child we want to dorsiflex the foot and then we take the X-ray. Okay, so stimulated weight bearing AP and stress dorsiflexion lateral both feet. So anterior posterior and lateral view is the view of choice that we take in. So you see that there are a lot of ossification center. The best becomes, like USG becomes a good diagnosis in CTV. You can easily see in USC. Okay, and remember that the tibiocalcaneal angle. So there is this is your talus, this is your tibia, this is your calcaneum. So there is this angle made by the tibiocalcaneum. This is known as a Kite's angle. Kite's angle. Normally this angle is 10 to 40 degrees. If there is the calcaneum and the cuboid, the angle between them, then if it becomes parallel, there is high chances that this is a CTV case. Okay, we don't want the angle to decrease. Now equinus, varus, adductus, cavus. Cavus is seen in CAVE. Forefoot, midfoot, hindfoot, and this is towards the ankle joint. So there is something which is known as a Pirani score. This score helps us to find out the degree, okay, the amount of deformity in the club foot. It's okay just to know the name. So after the Pirani score, what's important for us to understand is the goal of treatment. So our goal of treatment is to just treat the condition initially. Do not wait for a lot of time. Okay, just treat it initially. Reduce or eliminate all the foot deformities. Functional, pain-free, plantigrade foot with good mobility without calluses and does not need to wear modified shoes. Okay. Rather, it's written here, does not need to wear modified shoes. But whenever we talk about Dennis Brown splint and CTV shoes, after correcting CTV shoes, at least it's better you use it for 3 to 4 years. Okay, CTV shoes. Okay, at least after deformity correction, until and unless the child doesn't walk, you have to use Dennis Brown splint. Like if the child is non-ambulatory. Okay, non-ambulatory. After the child has started to walk, you'll use CTV shoes. And you'll use this until and unless 3 to 4 years. Okay, 3 to 4 years, at least 3 to 4 years, so that it becomes better. Now, the basic objective of the treatment of the club foot is to correct abnormal tarsal relation, to maintain reduction, to establish muscle balance between extents, everters, and investors, and to provide mobile foot with normal functioning weight bearing. Now, there is Ponseti method, Kite's method. Okay, the major one being the Ponseti method. Now, what are we going to? I'll just give you an option right from this slide, and then we'll move on to the other slides. Okay, see here. So in Ponseti, first of all, for 0 to 2 weeks, the mother will manipulate. Okay, the mother is taught how to manipulate the foot. Mother is taught to manipulate. Write it down. Manipulate the foot. Okay, the mother is taught to manipulate the foot. But after 2 weeks, the doctor is responsible, and the doctor, he goes under manipulation, and he uses above knee POP cast. Okay, POP cast. Above knee POP cast, use it. Okay, up to the metatarsal head and up to the and the fulcrum of correction. Fulcrum of correction is the tarsal head. Okay, tarsal head. And if in case there will be too much of correction is known as rock or bottom foot. So rock or bottom foot is basically the deformity that you see. The treatment started by the doctor at least by 2 weeks. Okay, manipulation and correction of the deformity is done. Okay, and it's like a serial manipulation. Manipulation is held in for 1 week, and again you use a cast. Till 1 week you use a cast, then remove the cast, remanipulate the deformity, maintain the cast again. Okay, and by this method you have to use the cast for at least 5 to 6 times. That will be at least 5 to 6 weeks. Okay, 5 to 6 weeks of serial manipulation. After that, you use the same I told you, no, over here, Dennis Brown splint. Okay, until and unless the child walks. After the child walks, use CTV shoes. Now, if the child presents late, suppose if the child, okay, I'll make a new slide over here. Okay, if the child presents late presentation. So what will you do for someone who is presenting late? For late presentation, you are going to go for serial manipulation. Okay, and what are the serial manipulation? I'll tell you. So from 0 to 1 year, you will be using Ponseti serial method, serial manipulation and casting with Dennis Brown splint, and CTEV shoes for at least 3 to 5 years, till 3 to 5 years of age. Okay, it's good if you use till 5 years, but a firstborn child, male child, and you are using the CTV shoes, the parents, they become so conservative that they do not use the CTV shoes, and that leads to recurrence. That is why counseling is very important, to use the Dennis Brown splint, okay, and the CTV shoes. After the child starts walking, Dennis Brown splint is used only at the night. Okay, during the daytime, when the child is ambulatory, use CTV shoes. At the night, use Dennis Brown splint. Okay, if the child is non-ambulatory, then just use Dennis Brown splint. Okay, 1 to 3 years of age. At the last, we have more than 10 years. Okay, then you have 0 to 1 year, 1 to 3 years, 3 to 5 years, more than 10 years at the last. Okay, this I'm writing in this way so that you don't forget it. 5 to 8 years and 8 to 10 years. Okay, exactly 2 to deformity. 2 years, 2 years, 2 years, 2 years deformity, more than 10 years. If it's more than 10 years, you have to go for triple arthrodosis. 0 to 1 year is Ponseti method. 1 to 3 years, you have to go for Turcos procedure. So what is Turcos procedure? In Turcos procedure, you are going to cut posterior, medial and posterior band, okay, of muscle, of basically fiber, which has been fibrosed. And 3 to 5 years of age, what you are going to do is, you are going to go for calcaneo-cuboid fusion. And this fusion, it is known as Dillman's-Evans procedure. DILWYN, Dillman-Evans, Evans procedure. And 5 to 8 years, what you are going to do is, you are going to go for osteotomy. That also, what you are going to do is, you are going to go for wedge osteotomy, like a wedge. And where are you going to cut? You are going to cut towards the calcaneum. Okay, and 8 to 10 years, what you are going to do is wedge tarsectomy. Triple arthrodesis is important. This is your tibia, this is your talus, this is your calcaneum, this is your navicular bone, and this is your cuboid, right? This is cuboid, this is calcaneum, this is your talus, this is your navicular. So what are you going to do is, you are going to go and fuse this like a T, like this. So you're going to fuse talonavicular, calcaneocuboid, and you're going to fuse talocalcaneal, sorry, like this, like a T you are going to fuse. This is triple arthrodosis. Arthrodosis means surgically fusion, okay. Ankylosis means pathologically it has been fused, that is known as ankylosis, okay. Osteotomy means you are going to cut it like a wedge and you are going to cut it towards the calcaneum, okay, calcaneum. So that is known as Droyer's osteotomy. It's basically, why are we doing all this? In the 1 to 2 years, there will be soft tissue, soft muscle will actually be fibrous, because of which what will happen is, there will be contraction, and contraction will lead to varus or equinus deformity, right? In calcaneocuboid fusion, what we need to understand is, basically the bone has fused, okay? So there will be soft tissue contraction also, and forefoot adduction also, right? And why are we going for osteotomy? Because there will be bony varus. There will be bony varus. That is why we are going for osteotomy also. Okay. Ponseti method, Turcos procedure, calcaneocuboid fusion, osteotomy, wedge tarsectomy, and triple arthrodosis. Okay. So this completes our lecture on CTEV. I hope what's written extra, I'll just go through this one. See, non-operative method, Ponseti, you have to correct it in this way. Okay, so next what you need to remember is you need to cut the Achilles tendinectomy, as well as you have to cut the posterior medial fiber cut. Okay, and that is known as, that's Turcos procedure. Turcos procedure. Okay, that is known as tendo Achilles and tibialis posterior. Okay, tendo Achilles and tibialis posterior. Tibialis posterior. And after another 3 weeks of plaster cast, immobilization in a Dennis Brown splint. Okay, and after Dennis Brown splint, use it for 4 to 5 years. You need to use a CTEV shoes, because Dennis Brown splint, keeping Dennis Brown splint and keeping the child immobility, unmobile, it doesn't work good, right? So stage 1, stage 2, stage 3, stage 4, stage 5. That means at least 5 to 6 weeks you have to go for clubfoot treatment. Okay, this is known as Ponseti method. Now cavus, adductus varus and equinus correction. In this way you have to correct. Okay, tendonectomy, posterior medial soft tissue release. Okay, sometimes in tendonectomy you get a short note, like local anesthesia is used. Okay, apply thin gauze over the wound, press for 5 minutes to stop bleeding, apply final cast like this. Complication, pressure sores, loose cast. Next will be surgical treatment by age. And if in case it's a bony type, you can also go for other techniques which can use is, we can use Ilizaro and we can use Jess. Okay, Ilizaro and Jess can be used. Okay, thank you everyone. This was all about your CTV. So this is the summary of the lecture. Okay, thank you.